Hello, today we're going to be talking about the updates to the 2021 Central Arizona Regional EMS Guidelines. The good news is that there are significantly less changes compared to previous years. We really take your feedback seriously, and many of your suggested changes were made this year. As you work through the updated guidelines, if you have any feedback, please forward it through the EMS division. We meet throughout the year and update the guidelines based on user feedback. One of the things I've noticed in talking to people about the guidelines is that we didn't emphasize the importance of getting comfortable with the app and how to use it. If you haven't downloaded the app to your phone or tablet, I would recommend doing so. The app is free. It's really important to get comfortable using the app before you end up needing it on a critical call. One of the things that I found I've done is to actually download the app on my phones, and periodically, if I'm waiting in line or sitting around, I'll just kind of look at the app and get more comfortable and figure out where things are in the app itself. To download the app, it's important to recognize that this is not in the normal app store. If you have not downloaded it yet, these are the instructions on how you would download this. You would go to the website that's listed here. On the left-hand side, there's a tab with different states. You would click on Arizona, select Central Arizona Regional EMS, and then once you click that, you should get a pop-up window to download this. There's several features in the app which make it easier to find guidelines, and we'll go over those shortly. One of the really good features of the app is the search button. Many people who've used the app are not aware of this, but when you first open the app itself, at the very top, you'll see a search bar. You can type in anything at the top, as I did here, just starting to type in the word agitation or agitated, and right at the top, you would get that guideline. If you're on a call where you're trying to find a specific guideline or a specific medication, you can use this very readily to help find that specific part of the app. Another feature which is very useful is the quick reference or favorites. At the bottom of the home screen, you'll see that there's various buttons, one of which is a favorite. So you can go into any specific guideline itself, and if you want to add that to your favorite, you would just star that, and that would sit in your favorite column on the home screen. Again, if you have specific guidelines that you like to reference on calls, this is something that makes it much more easy to use. One of the changes that we made this year was to update the verbiage from chemical sedation to pharmacologic management. Ketamine has gotten a lot of negative attention in the national media over the last 12 months. Nationally, the trend is to emphasize that we are really treating a medical emergency and not sedating someone unnecessarily. And this is the rationale to change the term from chemical sedation to pharmacologic management. One of the other changes we've made has been to remove IV ketamine. The rationale behind this is that if someone is agitated enough to need ketamine, we should be administering it IM or intranasal. If we can establish an IV safely, it is unlikely that the patient would need ketamine IV. IV ketamine is extremely potent and is associated with higher rates of respiratory depression and complications. We also added clear language stating that ketamine is not indicated in pediatric patients. And for all three medications, midazolam, lorazepam, and ketamine, we clarified the dosing intervals for repeat doses. So you'll see here at the bottom with midazolam, it would be 5 milligrams, may repeat every 3 minutes for a max total of 20 milligrams. Lorazepam, 2 to 4 milligram intramuscular or 2 milligram IV/IO. Repeat once every 15 minutes, max total dose of 4 milligrams. And ketamine, 4 milligrams per kilogram, IM or intranasal, max 250 milligrams per administration, may repeat once after 5 minutes. Again, if you had a longer transport time and you needed additional medication, you could always contact online medical direction for additional dosing, but your offlines do at least allow for 1 repeat dose of both medications. For the tachycardia guideline, we've added a hyperlink for pharmacologic management for synchronized cardioversion. I'll go over that guideline itself in the next slide. The other thing that we clarified was diltiazem dosing for the elderly. One of the things we wanted to clarify was if you look at diltiazem with patients who are greater than 65, that you're going to give a maximum 10 milligram per dose. So when you do your calculation, if you have a 100 kilogram patient, their dose would theoretically be 25 milligrams. For a normal, or not normal, an individual less than 65, they could get 12.5 milligrams initially. However, if they were 65, they would be maxed at 10 milligrams. So if you needed to repeat that repeat dose would again be 10 milligrams as well. So that's why we added that clarifying language under the diltiazem. So this guideline was added for pharmacologic management for synchronized cardioversion. If a patient is unstable enough to need cardioversion but is not unconscious, you would want to medicate them. This patient will be treated with fentanyl, and your dose will be 1 microgram per kilogram dose, intranasal, IV, or IO. The max initial dose is 100 micrograms. Your max total dose would be 200 micrograms. If a patient is over 60 years of age, you would want to consider reducing the dose by half. Keep in mind, if a patient is hypotensive, you would want to maybe give a smaller dose just because there is a small association of hypotension even with fentanyl use. This guideline does hyperlink directly from the tachycardia guideline as well. One of the big issues that we've had for many years has been the inconsistent magnesium dosing. One of the things we looked at with this year's update was to try to clarify both the doses as well as the duration of how the magnesium should be administered. As a result, with this update, all magnesium doses are listed to be administered over 5 to 10 minutes. The other delineation we made was to basically spread the doses between OB and all other uses. So for all the OB guidelines, your dose would be 4 grams over 5 to 10 minutes. And for all other guidelines for adult patients, the dose would be 2 grams over 5 to 10 minutes. There are 3 OB guidelines that include magnesium. And again, with this being the OB dosing, this is 4 grams. So for the seizure guideline, this would be if a patient is 3rd trimester of pregnancy or postpartum up to 6 weeks and having a seizure, your dose of magnesium would be 4 grams over 5 to 10 minutes. In the 2 childbirth and OBGYN guidelines, this is listed as a patient with signs or symptoms of preeclampsia, so blood pressure greater than 140/90, and blurred vision, dizziness, headache, altered mental status, peripheral edema, or abdominal pain / nausea and vomiting. For both of these guidelines, the dose is 4 grams over 5 to 10 minutes. For the cardiac dosing for magnesium, again, this is a simple 2 grams IV. If you look at the bottom of the tachycardia guideline for torsades, you'll see the dose listed as 2 gram IV over 5 to 10 minutes. And again, listed on the cardiac arrest algorithm for a patient in cardiac arrest with torsades, again, it would be 2 grams IV over 5 to 10 minutes. For bronchospasm, this one is worded a little bit differently because we have combined adult and pediatric dosing since the medications are the same for both adult and pediatric patients. For magnesium, your dose will be 40 milligrams per kilogram IV. And the dose for this is max of 2 grams IV, and again, administered over 5 to 10 minutes. One of the other changes that came up this year were the updates to the AHA 2020 guidelines. One of the things we wanted to emphasize is they did put some clarification to language regarding ventilation rates with pediatric cardiac arrest. Under the EMT section, as well as the paramedic section, there's specific verbiage that we've added to clarify that once you have a definitive airway placed, so you've either placed an iGel or have intubated the patient, you would want to continuous chest compressions and give a breath every 2 to 3 seconds. So this is a little bit faster rate than what was previously recommended, but this is the updated verbiage in the AHA 2020 guidelines. So again, for both EMTs and paramedics, once you have your definitive airway in place, so either your iGel or ET tube, you want to do continuous chest compressions and give 1 breath every 2 to 3 seconds. The other update on here is, again, dosing for torsades. So for this, you've got your magnesium sulfate, 50 milligram per kilogram IV or IO, and your max dose is 2 grams over 5 to 10 minutes. One requested guideline that we added this year was a thoracic injury management. This has been added to the trauma section and hyperlinks to both the general trauma and trauma termination of resuscitation guidelines. This has specific care and recommendations on how to identify potential pneumothorax, intentional pneumothorax, and also tells people how to actually perform needle decompression. Again, this is something that's a good, useful guide as necessary and talks about the ability and importance of placing this needle as necessary. For the dermal chemical burns, adult and pediatric, we have added a hyperlink to cutaneous calcium gluconate gel. If you look under the paramedic section, if a patient has exposure to hydrofluoric acid and you have calcium gluconate gel available, this can be applied, and we've added that to this section. We also recognize that the pain management had previously been listed under the EMT section, and so this was moved to the paramedic section for clarification purposes. For the acetylcholinesterase inhibitor poisoning, i.e. nerve agents, organophosphates, and carbamates. We did get some updates to the atropine dosing as recommended by toxicologists. The recommended dosing is now updated to read 2 to 6 milligrams IV or IO, and you want to repeat doses, which should be double the prior dose as needed every 3 to 5 minutes until there is a response. And you want to assess the patient for resolution of bronchuria, improving vital signs, drying of airway secretions. The same verbiage is also being added to the pediatric side, and it's 0.1 milligram per kilogram IV or IO, up to 1 to 4 milligram doses, and again, double the prior dose as needed every 3 to 5 minutes. The talk box also had some clarification language, which was not accurate per toxicology, and so we have removed that previous language as well. Part of the 2020 AHA guidelines has been an update to atropine dosing for bradycardia. The dose was changed from 0.5 milligram and was increased to 1 milligram IV every 3 to 5 minutes with a max dose of 3 milligrams. This is on the adult side only, and so you can see this here under the paramedic section, atropine sulfate, 1 milligram IV/IO every 3 to 5 minutes, a max total dose of 3 milligrams. For pain management, we did add some language regarding how to actually administer ketamine IV safely for pain management. There's a couple reasons for this. One of them being that studies have shown that if the ketamine is administered too fast as an IV push, people are more likely to have an adverse reaction. And so the recommendation with the ketamine is to either administer slow IV push over 3 to 5 minutes, or what you can do is take the ketamine, dilute it in 50 mLs of normal saline, and just infuse that over 3 to 5 minutes. Based on the very small quantity that you're going to be administering of the ketamine, it would be much easier just to utilize that ketamine, which is a 0.25 milligrams per kilogram, a max dose of 25 mgs. You would take that dose of 25 milligrams, mix that in 50 mLs of saline, and then infuse that 50 mLs of saline in over 3 to 5 minutes. We also added clarification language that ketamine is not indicated for pediatric pain management. One of the other changes was to specify that when we're looking at medication management, the medications are morphine or fentanyl or ketamine. So we want to really try to avoid mixing different medications without online medical direction. So we want to clarify and add that or statement between the different drug options. So for the adult and pediatric, you can use morphine or fentanyl. For adults, it would be morphine or fentanyl or ketamine. So you have 3 options for adults for pain management. For pediatric patients, you would have 2. On the sepsis guideline, we try to clarify some of the language in the top box to hopefully make it a little bit more clear. So we wanted to demonstrate things that could be signs of a suspected infection or immunosuppression. So if someone had open wounds, sores, cellulitis, if they have an indwelling medical device, recent surgery. And then we also added in some high-risk criteria, so things that would make someone at risk for having a severe infection or sepsis. So this would be anyone who's had a transplant, immunocompromised, so chronic steroid use, malignancy with chemotherapy. So that clarification language was made in the top box. We then look at criteria that increases risk of severe infection. So looking at the patient's vital signs, are they tachycardic? Is their respiratory rate increased? Are they hyperglycemic? So they have a high blood sugar in a non-diabetic patient? Do they have altered mental status? And the key thing with pediatric patients is recognizing that often a child's mental status may really be their sign of sepsis. So kids are going to have more demonstration of altered mental status, as we would sometimes see in the elderly patients as well with sepsis. For step 3, we wanted to clarify that these are findings of shock. So if you have these symptoms, these would be findings of shock, and you would want to treat the patient per the shock guideline. So IV fluid administration and push dose epi as needed. So if someone has symptoms of shock, you could then hyperlink to the shock guideline and then treat the patient's shock with IV fluid boluses and push dose epi. One of the things that we realized we had not brought over from the AIMS Red Book was language regarding when to use the IO in critical life-threatening conditions. So in bold on this page, we added in the verbiage that we had in the AIMS Red Book previously, and it states when IV access and drug routing is specified, it is intended to include IO access. So what that means is anytime you're going to give an IV medication, you can also give that medication IO as well. and any medication that needs to be given in a life-threatening situation, IO is preferred. So it's definitely a good option. One of the things to really remember is that a humeral head IO has significantly faster flow rates in comparison to proximal tibial IO. And so we really want to make sure people get comfortable with using that technique. If you look at the actual flow rate differences in a humeral head IO, the flow rate is approximately 5 liters per hour. In comparison, the tibial IO is 1 liter per hour. So when you look at some studies that show that an IV is preferential to an IO, that's because historically most of those studies were comparing a tibial IO to a peripheral IV. If you look at the flow rates, you can quickly see why a humeral head IO would be a much better route for administration. Just a couple things when we look at IO needle placement. Many of us, I think myself included, when we were first trained on using IOs, we kind of hubbed the needle into the skin. But really the key thing is you need to have the black line visible at the skin surface, which would mean that there's a gap between the cap of the needle and the skin itself. So in order to actually see one of those black lines, you need to have a gap between the color of the cap as well as the skin itself. So just a reminder when you're placing the IO, especially in young children, that if you really want to make sure you don't hub the IO needle all the way down. And just a couple of things with positioning on the humeral head IO, again, kind of making sure you're coming in at that 45-degree angle to the humeral head to get into the right location. And again, leaving that space in place between the skin so you see one of those black lines visible before you hub the needle. One of the requests that we did get from the field was to update the fluid boluses for hyperglycemia. For some reason, we had a really odd fluid bolus before, and we recognized that this is a patient that in general, if someone is hyperglycemic, they can easily do with IV fluid bolus. And so we just made it much more simple and said if you have a blood sugar greater than 250, symptoms of dehydration, vomiting, or altered level of consciousness, you can give a 20 ml per kilo bolus with a maximum of 2 liters. And this is for both adult and pediatrics. So hopefully that fluid bolus language is a little bit more user-friendly. We also reformatted some of the treatment for hyperkalemia. Again, if you're not sure if someone may potentially have hyperkalemia, you have them on the monitor and you see something that may be abnormal, you can click on the hyperlink for EKG changes in hyperkalemia, and it will show you some of the classic findings that you would see with hyperkalemia. So your peak T waves initially, widening of the QRS complexes, and ultimately the sine wave. If you see any of those findings, you have the option to use calcium gluconate or chloride, and you would want to administer albuterol as well because that helps shift the potassium. On the anaphylaxis and allergic reaction guideline, the only change we made was to the bottom box. Previously, we mentioned having to administer 60 ml per kilo bolus before you continued with push dose epi. This was discussed amongst the Valley Medical Directors Group, and everyone felt very consistently that if someone is in anaphylaxis, you've given your initial dose of IM epi. If they're still hypotensive, you don't want to wait until you've given a 60 ml per kilo bolus to give the push dose epi. And so we wanted to really clarify that you can give the IV fluids as you're administering the push dose epi. So we took away that specific reference and we added the hyperlink to the push dose epi dosing. So again, anaphylaxis, you would give your initial IM dose, which can be repeated every 5 to 15 minutes. But in the interim, if they're still hypotensive, you'd want to infuse your IV fluids and then go to your push dose epi to help support the patient's blood pressure in the interim. For altered mental status, we just did some reformatting per request of some of the users in the field, and then also just remove the reference to IO naloxone. Again, we're trying to clean up some of the guidelines. Anytime IV is listed, you can administer something IO as well. The fluid bolus is hopefully a little bit more clear. We basically just said administer IV fluid bolus if indicated and refer to shock. Part of the reason for this is that many patients with altered mental status may have something that is completely unrelated to a hypotensive event. So if someone is in renal failure and they're altered because they're uremic, that person certainly wouldn't need a big IV fluid bolus. So kind of recognizing what's the cause of their altered mental status, give fluids if indicated, and if they're in shock, you would treat the shock itself. This is one of the appendices that was just updated. This is clarified to state that these are abnormal pediatric vital signs. It was listed incorrectly before as pediatric vital signs. This is, again, one of your appendix later in the guideline app. But if you look at these are all kind of abnormal vital signs. So it's got your typical blood pressure calculation, and then kind of looking at your temperature readings, heart rate, respiratory rate based on age. So again, if you needed a quick reference trying to determine for a young child, are these normal vital signs? Is this abnormal? This is where you would find that data now. One of the requests that we had from the field was to add trade names to the drug profiles. We added these to the most common drug profiles where people are more familiar with the trade names. These include Cardizem, Ativan, Versed, Solumedrol, Atrovent, Narcan, Valium, Decadron, Zofran, Benadryl, Pitocin, and Neosynephrine. Again, once these are in the app, you can use that search bar to help find these medications if you're looking quickly for them on a call. I just want to touch briefly on some EPIC TBI reminders. It is really important to provide supplemental oxygen via nasal cannula at a minimum to all patients with potential head injury or multi-system trauma. I think with COVID, we've become focused on not administering as much oxygen, but it's really important to remember that patients with head injury and potentially TBI really need that supplemental oxygen up front. So at a minimum, if we can provide supplemental O2 via nasal cannula, we can then provide the surgical mask over this to help protect you guys in the back of the rescue. One of the things that I have seen pretty frequently in the hospital when I do follow-ups regarding trauma patients is that a trauma patient will come in from a gunshot wound or motor vehicle crash, and then it turns out that they have active COVID. So obviously we're not really thinking that when someone initially comes in, but this is why it's so important to wear your enhanced precautions. So your N95 and eye protection on every call. And just remember, put that surgical mask on the patient, even trauma patients, in the back of the rescue. That's a pretty high risk exposure. The other key piece with EPIC is don't wait for the patient to become hypotensive to administer IV fluids. So you really want to start IV fluids on multi-system trauma patients and really want to start giving IV fluid boluses before they become hypotensive. Once they reach a point where the systolic pressure is less than 90, we're really behind the 8 ball, and starting those IV fluids early is really important. If you are providing ventilatory support to the patient, so if you're bagging them either with an OPA, iGel, or ET tube, you really need to monitor your end-tidal CO2 levels closely. Again, just that caveat of the ventilatory EMT, having someone monitoring your end-tidal CO2 levels to really make sure that you're not hyperventilating a patient. It's really easy, especially with critical patients, to get distracted and go at a much faster rate than intended. A key thing to remember is to avoid the H-bombs. So Arizona has gone a ton of attention really around the world regarding EPIC TBI program and improving outcomes for citizens across Arizona. So we want to make sure that we avoid hyperventilation, hypoxemia, and hypotension. Our goal oxygen sat is greater than 90, a systolic blood pressure greater than 90 for adults, and end-tidal CO2 levels between 35 and 45. Since this is recorded, if you have any questions, please feel free to reach out to me directly via email or via your EMS division. Thank you.